Hello, good afternoon. Um, I'm just going to ask if the right screen is showing and make sure people can see the right screen. Okay.
Yes, you're all good.
Okay, great. So good afternoon, everyone, and welcome to the webinar Remission is Possible, a new way to think about type 2 diabetes, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Rose Young, and I'm the medical director here. And the Office of Lifelong Learning is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everybody committed to addressing the challenges related to diabetes. We'd first like to acknowledge that we are coming from Treaty 6 territory, the traditional ancestral territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as being part of the Métis homeland. We acknowledge the many First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. We are grateful for the traditional knowledge keepers and elders who are with us today and those who have gone before us. We make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. I'd like to start with some housekeeping. Please use the chat feature if you have a question about technical difficulties or L3 programs and services. If you have a question for the speakers, please use the Q&A feature of the webinar. You can review what has already been asked and upvote the questions you would like answered in the Q&A at the end of the session. We cannot guarantee that we'll be able to respond to all of your questions. A recording of the webinar will be sent to email to all those registered. Participants can claim CME credits and complete a personal development activity using My L3 Plan tool. For more information, visit the QR code. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today is my pleasure to introduce Dr. Brendan Byrne, who will address the topic of type 2 diabetes remission and how we can help more people reverse underlying insulin resistance and improve glycemic control through a virtual care lifestyle medicine program. He has been a physician and digital pioneer for the last 25 years and is Chief Medical Officer for Lifestyle RX, an organization that is empowering patients with their own data by developing a full stack virtual care solution focused on type 2 remission. He has a deep passion to use the latest science to help people optimize their health and believes that each one of us need our own wellness practice, something that's fun and energizes us while optimizing our health. So thank you very much for joining, and I will hand the screen over to Dr. Byrne.
All right, thanks so much, Rose, and thank you for everyone attending. This is a great opportunity, and I really welcome all the questions at the end. So really kind of what we want to talk about is a lifestyle medicine approach to type 2 diabetes and really kind of a new way of thinking about diabetes. So we're really going to hit on, lifestyle first, improvement inevitable, and remission possible, kind of the three kind of components here. But first I want to go back a little bit and really kind of look and talk about type 2 diabetes. When you look at the numbers and you go back to them, it really is stunning. And I know we see this in our practices, but 1 in 3 North Americans have diabetes or prediabetes. 6 out of 7 with prediabetes probably don't know it. It's consuming a huge part of our economy, and it's really kind of preventing us from doing other things that we could do in healthcare. When we look at the prevalence, it's just shocking how much this has gone up. And in fact, if you go back to 1960s, the prevalence was less than 2%. And so when we kind of ask the question, what's changed? The biggest thing that, of course, that has changed is our food. And we see huge changes in terms of the amount of ultra-processed foods in our diet. And when you look at it from a Canadian perspective, almost 50% of the total calories consumed by Canadians are ultra-processed. And this has a huge contribution to obesity, diabetes, as well as high blood pressure, really kind of all the metabolic syndrome issues. When we look at what's happening is we're simply not eating at home as much as we were. We're eating more fast food, we're eating in restaurants, and this doesn't really even take into account kind of the skip the dishes or the home food delivery. And so we're eating less of the food that we prepare ourselves. And when we're ordering that food, obviously the portions have exploded as well. And so really kind of what we're seeing is this lifestyle change that has happened during this time frame. So one of the things that's really kind of evident when you kind of take the step back is that type 2 diabetes really is in many respects a lifestyle problem. And too often we've attributed that to be an individual's lifestyle problem, but I think collectively it's a societal lifestyle problem. But we need different approaches. And so the conventional approach with type 2 diabetes has been that this is a chronic progressive disease. We can slow it down through lifestyle changes and medications, but really we're trying to just prevent complications. Medical treatment results in virtually no disease remission. Now this stat may change, obviously, with some of the GLP-1s. There is better alignment in terms of remission, but it's still pretty depressing. And when we look at it, kind of, the conventional approach is we start with one medication, we add, one or two more, and then after 10 to 12 years, a good number of our type 2s end up on insulin. And so the conventional approaches really aren't working because, we see this continued explosion in the prevalence. And so we kind of ask the question, since it's a lifestyle problem, and if we go back far enough, we can see the dramatic changes on the society. Is there another way? And a study that came out in 1992, about a year after I was in practice, so yes, I am that old, was a 10-year study, 10-year remission study for type 2 diabetics with Roux-en-Y bariatric surgery showing 70% 10-year remission. And so for a long time, we just attributed there's something special about bariatric surgery. Perhaps it's an incretin effect, perhaps there's something else. But in 2018, two studies were published that I think were really kind of landmark studies for those of us who are interested in lifestyle medicine. The first was the direct study. So Roy Taylor, Mike Lean, Newcastle in the UK, very well-known study, and really kind of the body of work that Roy Taylor has done was actually inspired by this observation of bariatric surgery and really kind of trying to understand what was going on there and was there something different. And the twin cycle theory, which we'll present a portion of today, is really kind of Roy Taylor's work at kind of, simplifying and unraveling insulin resistance and showing that the insulin resistance component is reversible. Direct was a primary care study. It was a randomized study. It was very high quality. And what they showed was about a 50% remission rate. But the remission rate correlated with the amount of weight loss. So greater than 86% remission when there was a 15-kilogram weight loss, which in that study was about 15%. The same year, 2018, Sarah Hallberg at Indiana published a study on a very low-carb diet approach, so a ketogenic approach. Very different nutritional approaches, very similar remission rates, slightly different criteria for admission. It wasn't a randomized trial, but when you dig into the results of it, what you see is that remission is possible, and also that remission does correlate with the degree of weight loss and the response to the lifestyle changes. So these two studies were really helpful in sort of pointing the way that remission is possible with lifestyle changes, and that perhaps we should be looking at this more. One of the things I always like to go back to are the guidelines, and kind of, circled in there, our guidelines really are the lifestyle behaviors and kind of the healthy lifestyle behaviors and self-assessments. And so that's really kind of, where we should be started. It's a lifestyle disease. We know that lifestyle can help, but let's go back a bit in physiology and look at why lifestyle should come first. And I think when you really start going back in the physiology, it becomes even more clear. So really simply, diabetes, condition where your body does not make enough insulin. If we, simplify that or break that out a little bit, it's either because the beta cells in the pancreas can't make enough or release enough insulin, or the insulin doesn't work properly. Put another way, it's that pancreatic beta cell capacity versus insulin resistance. And if we kind of think about this, like a balance, if we have, if there's no insulin resistance and our pancreatic function is normal, then obviously our hemoglobin A1C will be normal. But that balance is going to determine what happens with our blood sugars. In type 1 diabetes, the autoimmune process, destroys the beta cells, and we see, minimal to no insulin release. So of course it tips out of balance. Insulin resistance in type 1 diabetes is just going to make things worse. In type 2 diabetes, for most people, it's insulin resistance that's the problem. So there's often normal or elevated amounts of insulin, but it's not enough to overcome the insulin resistance, and you tip out of balance as a result. So let's look at insulin resistance. Insulin resistance, I think the best way to really think about it in kind of a way that we communicate to our patients is insulin resistance is actually a whole body response to energy overload. So energy, of course, we get from the food that we eat. And if we eat more energy, if more energy is coming in than we're using, we're going to store that extra energy as fat. And so initially we'll store that fat in our healthy zone. So the gluteofemoral zone, so kind of our hips, butt, legs, kind of subcutaneous skin, subcutaneous fat. But when that fat gets full, we start to leak over, we start to spill over, and you start to see this belly fat. And people cross this concept of our personal fat threshold. So that point at which we stop being able to store healthy fat and we tip over and start to store visceral fat is really this concept of a personal fat threshold. And the way I like to explain this is that each one of us actually has a different personal fat threshold. And if you look at the science of adipose tissue, what we see is there's genetic components, there's epigenetic components, early childhood has influence, and childhood development has an influence. But largely by the age of 18, we've got a fixed number of cells in our healthy fat zone, and we don't tend to increase the number of cells. So as we gain weight, we put more fat into those cells. Some people have, a bigger capacity than other people. And so, if you're somebody that has a bucket-sized, personal fat threshold, you're going to spill over much more quickly than somebody who's got a bathtub. And this explains kind of the concept that we see of metabolically healthy obese patients who have a large personal fat threshold. They're able to store a lot of fat in the gluteofemoral zone, and that offsets kind of their risk in terms of insulin resistance. On the other extreme, we see people with lipodystrophy that can't store any peripheral fat and run into problems with insulin resistance very, very quickly. And so on the outside, we see this, this visceral fat we really start to see correlating with our waist circumference. So this is kind of one of the most valuable things that we can do and track for patients, is really just be sure that they're not gaining fat here. On the inside, it's actually fat within the cells of the muscle and of the liver, and again on the pancreas, that affects insulin resistance and affects this whole process that leads towards type 2 diabetes. When we look at it, we really also can kind of focus on the liver. So most of the insulin resistance is going to be driven by hepatic insulin resistance, which is really correlating with fat in the liver. So that fat that spills over and starts getting stored viscerally, some of that fat ends up in the hepatocytes. And as it does that, the liver doesn't respond properly to insulin. This, of course, is important because when we're not eating, it's our liver that's producing blood sugar, right? So our liver is constantly producing a little bit of blood sugar when we're not eating. If it's not responding to insulin, it's not actually getting the brake signal in terms of the glucose production, and it produces a little bit more glucose. What happens very quickly, though, is the pancreas responds by cranking up a little bit more insulin. And this cycle, as fat is deposited in the liver, this cycle goes on. We start to see higher and higher levels of insulin to the place we get too much insulin. I think the best way to kind of think about this is looking at it graphically. And so if we compare glucose to insulin over time, what you see is as the liver fills with fat, the pancreas responds by cranking up some more insulin. And so what we end up with is normal blood sugars, because we're able to produce enough insulin in order to maintain normal blood sugars, but very, very high levels of insulin. And this is what you see in metabolic syndrome, where somebody can have normal blood sugars, but as the insulin levels go up, we start to see the liver's exporting more and more triglycerides, HDL cholesterol goes down, waist circumference goes up, and often accompanying this is raises in blood pressure. And so normal glucose, but too much insulin. And the thing with insulin that we have to really remember is insulin is actually our body's response to food, right? So when we eat, that's when we normally get an insulin response. And insulin stores away the glucose, so it maintains blood sugar control. But insulin also is the trigger to store fat. And insulin also stores, it's anabolic, so it actually helps us store amino acids. But on the fat side, what happens is it helps us store the fat. It also inhibits fat burning. And so you get this kind of situation where insulin acts almost like miracle grow for fat. And so, one famous diabetes researcher has called this kind of, issue with these high levels of insulin. It's like somebody puts a turnstile on your fat. Fat can go in, but it can't come out, and you can't use it. And of course, this creates a vicious cycle because the reason it's going up is because of the fat that's in the liver. And if so if the insulin levels are going up because of the insulin resistance due to the fat in the liver, as higher levels of insulin are going to lead to more fat, and the cycle is going to go around and get worse. And it really feels like a vicious cycle for patients. If we look back and this is Roy Taylor's kind of twin cycle theory, that's the liver cycle. If we look at the liver's response, one of the responses is to pump out triglycerides. And so, we often kind of look at it from a metabolic syndrome perspective. 1.7 millimoles per liter, reaches the criteria for metabolic syndrome. But I think anything over 1 millimole per liter of triglycerides is actually signifying that the liver is actively trying to shed fat. And when it does that, some of that fat can end up in the pancreas, and that can blunt the pancreas's ability to respond. And you get into the second cycle, which is kind of where the beta cell capacity begins to reduce. And so you run into the situation of not enough insulin. And of course, not enough insulin is characteristic of diabetes. So if we go back to our graph, what you see here is as the pancreas becomes affected, the first thing that happens is it plateaus, right? So there's still a lot of insulin around, but it plateaus. It's no longer able to respond to increasing insulin resistance. And now we tip into prediabetes. And so I kind of like to say there's nothing about prediabetes. This is the marker that the pancreas is failing. It's failing to keep up. And we should be taking prediabetes, I think, much more seriously than we do take it. It takes a long time to get here. And often kind of when you measure insulin levels, they're 2 to 3 times normal. So the pancreas is really trying hard to maintain these sugar levels. But at this point in time, it's running out of capacity. If this goes on, what we see is, eventually reach the criteria for type 2 diabetes. And by that point, the pancreatic beta cells are really not healthy. There's about an 80% reduction in pancreatic beta cell function. The ones that are working really, really hard. And so we've really kind of, the pancreatic function is now falling off a cliff. So elevated glucose, not enough insulin. Back to kind of our model here, if we think about this as a balance, as insulin resistance develops, the pancreas compensates and the A1Cs remain normal. And that's that kind of early phase. That can go on for a while, and it really depends on the pancreas. How long can the pancreas compensate? How long can the pancreas continue to increase the amount of insulin to overcome the increasing insulin resistance? At a certain point, you start to see things tip. It just can't quite keep up. And that's kind of that first piece where we see prediabetes. And then we see it tip further as the pancreatic beta capacity decreases. So even with normal pancreatic beta cell capacity, it's no match for the amount of insulin resistance that's there, and we tip into type 2 diabetes. Meds can help, and they can help compensate, but they don't really address the underlying root cause always. But of course, one of the things that's so important to realize is that type 2 diabetes, not all type 2 diabetes is the same. There are different subtypes of type 2 diabetes. And it's actually important to understand this as we work with our patients so that we can kind of give them the right guidance. And so when we look at the subtyping, this emerged, I think initially in Sweden and has since been replicated in at least 11 different territories or countries and territories that I know of. And really it breaks down into 5 different subtypes. And I won't go through all the details of these subtypes. But really, you can kind of broadly think there's 2 subtypes that are insulin deficient subtypes. And the first one really, many of it's autoimmune insulin deficiency. We used to call it LADA. It's really the same process as type 1. So it really is a different category. The other insulin deficiency category, some of it's probably genetic. Some of it may be from other things that have happened to the pancreas, so pancreatitis and other things like that. But the other 3 are really relate back to insulin resistance. So the pancreas isn't the issue, it's insulin resistance. And this is where remission really is possible. The way to think about these subtypes, I think, is actually to think about it from the pancreas's perspective. And so if we flip this around, what we see is the 2 pancreatic deficient, there's no compensation. The pancreas is the issue. The other three, the pancreas is actually compensating, either moderately well or highly compensating or very high compensation. And that kind of, determines those phenotypes that we're seeing. When we look at it in our practice and from the patients that present to us, about 93% of patients actually come with with some degree of insulin resistance. So only about 7% are in the pancreatic deficient category for what present to us. In the studies, the balance is a little bit more like 76% in insulin resistance, about 3/4 in insulin resistance, and about 1/4 are actually pancreatic deficient. And that may just reflect kind of the bias in terms of people that reach out to us. So again, kind of one of the things that's so important to know is that Roy Taylor's work in the twin cycle theory and DIRECT really points the way to the fact that hepatic insulin resistance, which is really the driver here for in our practice at 93% and kind of overall probably 75%, it actually is all about weight. And so in 2020, there's a study in the New England Journal published and an editorial that really kind of said, I think kind of put a pin in it. Metabolic benefits of gastric bypass surgery and diet are similar, related to weight loss with no evident clinically important effects independent of weight loss. And so that kind of opens the way to this is predictably reversible if we can get the hepatic fat off the liver. And to do that, we have to lose weight. And so when we think of remission for patients that have insulin resistance, what we're trying to do is, lose the fat that's in the liver, restore the balance by decreasing the insulin resistance. And that really is kind of what remission is all about. How much fat? So the MRI studies are fascinating. There's about 400 grams of fat for somebody with type 2 diabetes with insulin resistance, tends to average about 400 grams of fat there. It's kind of like this pound of butter in their liver. Now, DIRECT kind of pointed that patients with higher BMIs, and the BMIs in the DIRECT study averaged around 33, I believe. And so with higher BMIs, we see it's probably about a 15% weight loss that it takes to get underneath that personal fat threshold and get back to a place where the hepatic fat is largely disappears. So it is a pretty significant amount of weight loss. Of course, as we said, there are, in our practice, about 7% and kind of across the population, about 25% where it's severe insulin deficiency. So it's pancreas's ability to produce insulin, that's the problem. The goal for these patients is going to be different. And so really kind of what we see here is the goal kind of becomes around glycemic control. And unless there's insulin resistance, you don't need to lose weight, right? It doesn't really make sense. So unless there's hepatic insulin resistance, you're not trying to lose the weight. So strategy is going to be similar for these patients from a lifestyle perspective, but the focus is going to be on glucose control. So one of the things I really want to, emphasize is not everyone's going to achieve type 2 diabetes remission, but a good percentage of patients can achieve that. Everyone, though, can benefit from a lifestyle medicine approach. And the challenge with lifestyle medicine and the challenge with working with people on lifestyle is not its effectiveness. Those of us who practice it know it works. The challenge has always been that it takes too much time. It's too hard to do within the scope of a practice in a 10-minute visit. You just can't do it that way. And so one of the things that we've done as Lifestyle RX, and it kind of was the silver lining of COVID, was we've built a comprehensive approach that leverages virtual technology. And so we start pretty traditionally with a kind of one-on-one consultation and some blood work to understand why a person has type 2 diabetes and what degree of insulin resistance they have and where their pancreas is. And we communicate that through some interactive reports. But then the patients begin to work through a curriculum online that helps them understand what to do. And then we pair that with weekly group medical visits that help a patient understand how they're going to make these changes in their own life. And so this approach with a personalized approach with expert guidance and community support is really what we're seeing drive the personal transformations that we're seeing. Our strategy, and I won't go into super amount of detail here, but the 4+2 is what we call the strategy. There's 4 kind of core elements of it. The first is a nutritional strategy, obviously. We don't count calories. We don't do the very low carb approach. We don't do the very low calorie approach. We actually have a principle-based way of helping people to eat in such a way that's going to help with their insulin resistance. So the first thing that we want to do is actually, and probably the biggest jump is making sure that people are not eating ultra processed foods. And so it's helping them make the switch from ultra processed foods to whole foods. And the key there is with whole foods, your body is able to detect the energy and protein content of those foods and adjust appetite and satiation much better than ultra processed foods. Ultra processed foods, I think, we call them stealth calories. They essentially hack your satiation system. You don't get the same signals from those foods. So first thing is whole foods. Lower glycemic load. So we have to emphasize, when patients are diabetes, they don't have enough insulin, right, to overcome insulin resistance. And so we've got to watch the glycemic load, how much glucose is coming in from the meal that they eat. So it's not low carb, because there are some carbs like, lentils, beans, pulses, legumes, so on, that are very slow carbs, and they're great. And they've got lots of fiber and protein, and we like them because they trickle in slowly with glucose. It's the fast carbs. So low glycemic load, high fiber. Fiber has huge benefits for patients with type 2 diabetes. And then relatively high protein. Really trying to make sure that patients are getting enough protein to be satiated, but also enough protein to maintain muscle mass, which is really the second part of the strategy, which is we need people to use their muscles. The muscles are the carbohydrate buffer. So when you eat a meal, 80 to 90% of your carbohydrate, the glucose from your carbohydrates should end up in the muscle if you're active and healthy. If you're not active and healthy, all of those carbs end up in the liver, where only a fraction gets stored as glycogen and the rest get turned into fat, triglycerides. The other thing is your muscles are your largest metabolic engine. And so they're tremendously helpful from a fat burning perspective. Third part of the strategy relates to the liver, since the liver is like a metabolic command center. Obviously, alcohol and fructose are going to be particularly challenging for your liver and will contribute to more liver fat. But also gut health. If you're getting digestive symptoms, it's often an indicator that there's gut inflammation. The portal vein drains from the gut into the liver. You get liver inflammation, and liver inflammation correlates with insulin resistance. So we have to kind of watch those factors. The fourth is really kind of restoring fat burning. And so here we take advantage of the circadian rhythm. So kind of the natural rhythm where we're kind of designed to, eat and be active during the daytime, rest and digest at night. We tend to flip into fat burning at night. And so we start with a 12-hour fasting period for people. And so we get them to the place where they have a 12-hour period where they're not eating. It helps with their gut health. But then we'll extend that, if we're trying to lose weight. And we'll extend that just because that may be the only time of day that people with insulin resistance are actually have insulin levels low enough that they can burn fat. And so we might extend it out to as far as 16 hours. We never go past 16 hours. And this really comes back to the fact that our muscles, end up being our protein depot. We don't store protein in our bodies. We don't have we store fat, we store carbs, but we don't really store protein. And so if you don't get enough protein in your day, then you'll actually start to lose muscle mass, which really is counterproductive in type 2 diabetes. The wild cards for us here are really kind of stress and sleep. They're kind of cortisol mediated. Anything that increases cortisol will, of course, increase glucagon, and glucagon will drive more hepatic glucose production. And so you really kind of end up kind of with worse blood sugars. The way to think about our approach is our clinic overhead doesn't go to a landlord, an absentee landlord with expensive lease. It goes towards educational tools for patients. We develop these personalized reports where we actually show people their own data, and we walk them through kind of that data to really kind of fully explain why they're developing type 2 diabetes, and why this is happening. And then whether remission is possible for you. Is this an attainable and realistic goal? And then we link that back to kind of their habits and behaviors. And so we give them some guidance around that. So we start with that kind of up front, where people have a really clear understanding of why this is happening and what they can do about it. The 12-week curriculum with the medical visits and the online curriculum, each week has a core behavior, and it's staged in such a way that in the foundation phase, people will make fairly dramatic changes, and they'll actually get a lot of success with that. which gives us a little bit more time to come back on nutrition and go through some of the principles of nutrition, which can be complicated and it feels complicated at first. What the heck's 30 grams of fiber? And then we come through what we call fine tuning, which really is anything but, sleep, stress, habit formation, and resistance exercise. And so that kind of gets them through the 12 weeks. People learn at their own pace online. So our online curriculum that they have access to forever, they watch these videos multiple times so that they understand. There's exercise, there's downloads. People, print out every week's kind of download and put it on their fridge. And then they come to the group, and the group is an amazing place because people get support here. They share their wins, they share their challenges. But most importantly, there's two things, and they kind of are almost kind of juxtaposed. They first realize they're not alone, and that's a huge thing when it comes to making this change. A lot of times people feel like there's something that's wrong with them, or that they haven't done what they should have done. And that's why they have this disease. And then they come onto a Zoom session and they see, oh my goodness, there's all sorts of people kind of in all sorts of category, at different stages of diabetes. And so they start to realize they're not alone. But they also realize that they're different from these other people, and each person has to find their own path. And so that's kind of the wonderful thing that really happens here is people start to realize, okay, I'm not alone with this, but I do need to figure out my own kind of strategy for my own life because I'm just different than other people. We work within the health system. So this program is 100%, publicly funded, and it's funded really off of the physician billing. So we get referrals from primary care providers as well as endocrinologists and internal medicine specialists. We deliver the program, so kind of what you've seen there, the 12-week program, as well as a monthly maintenance program. Patients get lifetime access to the materials, lifetime access to our community. They have an ability to follow up with us anytime, and we've got a team that is quite diverse now. So we've got a group of physicians that are, 42 now, that are lifestyle medicine physicians kind of first and foremost, but across different specialties. So we've got family doctors, internal medicine doctors, and endocrinologists all working with us to deliver this program. And really what we've done is we've taken that first part of the guidelines and we've created a lifestyle prescription for it. And this is what's so gratifying is, so if you look at those patients, the 93% where insulin resistance is the primary problem, this lifestyle prescription really works. And so what we see is, an average A1C of people presenting to us is around 7.8. At the end of kind of, and our delta between A1C measurements is currently averaging 141 days. They drop a full percentage point with about an 8.1% weight loss in that roughly that same time period. If we look at it and try to slice and dice it a little bit more, patients with normal pancreatic function start off a little bit better and end off a little bit better. Patients who have had shorter duration of diabetes end up better, so the pancreas, definitely best to get at this early. And if we look at it kind of that short duration, normal pancreatic function, that's kind of a sweet spot in terms of being able to see big changes. But really one of the things that we kind of said before was, even though we're pursuing remission for those patients with insulin resistance, everyone benefits. And in fact, when we look at 100%, so this is just all the patients coming in, that's our overall improvement, right? And so the patients with pancreatic deficiency, while remission is not really their goal, they improve to the same extent. And so we see this improvement kind of from 7.8% to 6.7%, and it goes across all degrees of control. So people that come in with poorly controlled diabetes end up with pretty good control. People start with pretty good control, end up with optimal control, and people who start with optimal control end up in the area that remission is possible. And we think that this is going to be something, and we're really excited about this, is over time, the longer people can be on the path and maintain the path, we think that many of those patients can start from poor and go all the way into area where they're a candidate for remission. I always like to come back to this because I think that there's so much we can do in healthcare that we can't do because of cost issues. I think that these reductions across every category are associated with huge decreases in healthcare cost. But probably most importantly is some of the feedback we get from people. And that feedback really comes down to it's life-changing. And this is what's, I think, so gratifying working in this area is just people's lives change. They're different people after this. They feel like they have this degree of control that they didn't have before. And kind of sprinkled throughout our comments, you'll see these kind of things around life changing. And we've got pages and pages of these, kind of feedback and testimonials. And it's just super gratifying to see people be able to do this. So if you're a primary care provider or you're or a specialist that's seeing patients with diabetes, what can you do? And so the first thing we say is you should have the lifestyle conversation with them. It's similar to what we learned from smoking, right? So what we learned with smoking is if a doctor, every time they see somebody with smoking, ask them about it in a non-judgmental way, over time, patients will take advantage of some of the things that we can do. So for a lifestyle conversation, really kind of the questions are simple. Asking the patient, do they know what the role of nutrition, exercise, sleep, and stress is on their diabetes? Do they have a strategy to improve those behaviors? Do they need help? And we think that there are times where people are more ready for change, and our program requires a lot of work, right? So 1 hour of medical, 1 hour of consultation time with a physician one-on-one is translated into about 30 to 40 hours of patient program time. So they spend a lot of time in 12 weeks on this, above and beyond making the changes in their lifestyle. So people have to be ready, and it's okay if somebody's not ready, right? It takes, on average, for somebody to quit smoking, it takes them 7 tries. We're okay with people kind of, not being ready to take on the program. But when they are ready, we want to be there for them. So time, new diagnosis. So obviously when somebody, tips into prediabetes or is diagnosed with diabetes, hugely important time. There's a lot of momentum there. When you're prescribing that first medication, maybe hold off for 3 months and encourage them to try lifestyle first. When they get a medication side effect, or you're thinking about a second medication, again, a really good opportunity. And of course, the quarterly cadence of the A1Cs is always a good opportunity. So, really kind of here that, when I just emphasize what we're doing is the first part of the clinical practice guidelines, but it's, I feel really great about the fact that we're able to really act upon it in a way that when I was doing primary care, I couldn't, right? I just didn't have the time or the resources to be able to really guide a person with what they needed. And so this lifestyle first approach, kind of based on the guidelines, you can see from the results, the improvement for patients is inevitable if they do the program, and remission is possible. And so, many of these patients will find a path all the way to, normalized or near normal blood sugars off of medication. And that's possible. Very individual discussion as to kind of what that looks like, but it is definitely possible. So I think I'll finish there and open up to some questions.
There are questions in the chat and the Q&A, Brendan. So I see in the Q&A from Anne Zhang, I'm sorry, I missed the part on how to be kind to the liver. Any practical tips? Okay. Yeah. So I think, the first thing with being kind to the liver is actually addressing the energy overload, right? So that's, the dietary changes will help there, as well as exercise and getting the muscles to take on their role to store the carbohydrate that you eat, kind of buffer those carbohydrates. Alcohol is very kind of obvious. And so kind of helping people understand the role of alcohol on their insulin resistance is very informative. And we see a lot of people really decrease the amount of drinking that they're doing because they really realize it's counterproductive. And fructose often, it often gets addressed as we eliminate kind of the ultra processed foods. It's not fructose from fruit, of course, it's fructose from sugar. The gut health one is a bit more interesting just because one of the things that we've learned, and this is kind of where interdisciplinary care is so great, from working with our dietitians, when people come into our program, we assess them across many different indices. One of the things we do is we run them through a gut health index that gives us a little score. And when we see a low score there, what we've learned is that if that score doesn't improve from the initial kind of 4 or 5 weeks when they kind of make the initial dietary changes in terms of shifting to whole foods, it often really helps for those patients to work one-on-one with a dietitian, put gut health first, because if they can get their gut symptoms to decrease, presumably their inflammation's going down,
we often see the weight loss and blood sugar control kind of happen. So we kind of prioritize that first when we see kind of the real gut issues.
Thank you so much. And I see, Dr. Byrne, you've brought someone with you.
Yeah, so Andrea Collins.
Called Brendan. So
Andrea is our patient, our provider success person. So she actually works with practitioners to kind of help them incorporate this into their practice.
Okay, fabulous. So a number of the questions are being asked in the chat. I will remind everyone to please put the questions in the Q&A because that helps other people upvote. And I do know that we have allotted till 12:45, but given the number of questions, if we're okay, we'll extend to 12:50. That's okay with you?
That's fabulous.
Okay, so the next question is aiming for fasting for more than 12 hours. Some people say that the first 4 hours after eating is technically not considered as part of the fasting period. So do they need to not eat for more than 16 hours instead?
So we essentially count from their last meal to their first meal in the morning. And the core behavior that we try to instill is the 12-hour period. And it's really just kind of working with the circadian rhythm. With fasting, there's a lot of, there's been a lot of hype around fasting. There's a lot of different approaches to intermittent fasting. We really try to curtail that a little bit. We use it as a tool. It essentially cuts out nighttime snacking, which is hugely important and helpful because usually those nighttime calories aren't particularly useful. If it's hard and people are hungry, we actually say, you know what, it's time to eat because it just tells us that you're not burning fat yet. You're not flipping that metabolic switch. So we work our way to 12 hours and then we have to be careful at the 12-hour point. If somebody's on insulin or sulfonylurea, they've got to have specific guidance around how to decrease the dose because we don't want to get hypoglycemic events. And then we kind of work on the basis of you kind of bump it up as it's easy. So 12 is easy, maybe 13. You spend an extra hour in that fat burning window. At 16, we cut it off. And the reason is because we've got to get enough protein in. And so for most people, they're going to need to eat 30 to 50 grams of protein with each meal across 3 meals in a day. And so the challenge with that is eating more than 50 grams of protein in one sitting, you don't actually absorb any more of that protein into your muscles. And so you got to get it across 3 meals. You just don't have enough time if you do a 20-hour fast. And so you become protein deficient. And this is what's so important, is thinking about this from the whole body perspective. It's the thing that we see kind of one of the concerns that we all have with GLP-1s is when people, if you crank up the satiation signal, people stop eating, they'll also stop eating protein and they'll start to see muscle mass loss, which is going to be counterproductive. So you have to have a strategy for that. For us with the fasting, it's, let's 12 hours is kind of the goal. We'll extend it. If it doesn't fit into somebody's life, that's okay. We don't want them, fasting 20 hours. If they feel good at 14 hours, but feel crappy at 16 hours, 14 hours is the right number for them. We really take that feedback.
And just a technical question on, does having Timmy's with 3 cream and 1 sweetener break the fast? I.e.,
anything with protein or anything with carbohydrates will break the fast. And and I kind of chuckle with the question because it clearly comes from a practitioner who's had a patient say, I don't eat breakfast, but I do drive through Timmy's and get the double and a muffin.
A question on the program: who is helping patients implement the behavior changes? Is it doctors, dietitians?
Yeah. So one thing I was negligent when I described the group sessions is we have registered dietitians running the group sessions. So in Alberta, we don't have a fee code for group medical visits done virtually. In Ontario and in BC, we do. So those groups are run with both a doctor and a dietitian. In Alberta right now, it's our dietitians running the groups. But it's kind of nice because you think about it. So we're going through Alberta Health, so they're not paying for the dietitian. They get 12-hour access. We encourage people to bring all their questions because guess what? You learn from other people's questions. So But yeah, so we have kind of physician dietitians. We're just launching a program around sleep and stress with clinical counselors. We think that that's, for many people, their cumulative stress load is such that it's both causal and also kind of really gets in the way of making some of these changes, and that may have to come first.
Can you please comment if a patient becomes pre-diabetic and that is actually more in the middle of the pancreas burnout, is there any benefit to testing insulin levels or other ways we can find out who is more at risk for this metabolic syndrome before proceeding to diabetes?
Yeah, so this is something I feel really strongly about. Because we've traditionally thought about diabetes from a blood sugar perspective, but it's a bit like we have cars driving off the cliff and we've got the ambulance at the bottom. Obviously, things need to be done before they fall off the cliff. Pre-diabetes, even at an A1C of 6%, about 11% of people will actually have changes in their kidneys and eyes at that point. So we know that there's some damage being done. And when you look at the macrovascular complications of type 2 diabetes, they actually begin well before pre-diabetes. They correlate with the insulin resistance and insulin resistant levels. So we really should be identifying patients when they cross their personal fat threshold and start getting belly fat. And we should be starting to look for signs of insulin resistance. So the way we can do it kind of on a simple panel is if you do a lipid panel, the triglyceride over HDL ratio is a pretty good proxy. It's not perfect, but it's pretty good. Fatty liver index, which is a little algorithm that we use, which takes into account triglycerides, gamma GT, waist circumference, and BMI. It's actually pretty good as well, so it gives you some indicator. I can't tell you how many patients I see who tell me that 10 years ago I had an ultrasound for something else, but they told me I had a fatty liver. And nothing was done at that point in time. Yeah, so when you hear fatty liver, you should think insulin resistance. You should think that this is a person that may tip, over time. So I feel like, when we see these patients, one of the things that what we do is we do a HOMA-IR2. So we do a fasting glucose with a C-peptide. C-peptide is better than insulin because insulin's super volatile. It's released in a pulsatile fashion. If you do like 3 and 30 minutes, you get quite different results. C-peptide is more stable. You get a pretty good indicator. And I didn't go into as much detail around the 3 different insulin resistance subtypes, but the severe insulin resistance subtype is really interesting because these are people with super pancreases. They can produce a ton of insulin. And so by the time they present with prediabetes, you'll see their BMI is often around, between 35 and 45. They describe that they can't lose weight no matter what they do. And they can gain weight really easily. And when you explain kind of what's happening from an insulin resistance perspective and their high levels of insulin, it really becomes clear to them. And it's, frankly, a lot of those patients are quite emotional about it. Those patients we're doing a disservice to, right? Because they present really late. And so we really should be identifying this earlier and measuring insulin resistance when we're starting to see the elements of metabolic syndrome. And that's kind of where we should be addressing that.
Ed, maybe given the time, an important question: how does this program address realities of colonization and trauma on diabetes diagnosis, and how does this program reflect on the realities of food availability in many places like rural and remote areas of Canada?
Yeah, so really good questions, and I think first and foremost, kind of one of the big things that we do in our program, I think we do a really good job of up front is because it starts off with a one-on-one personalized consultation with a physician. We really do emphasize that first people have to find their own path, and their lives are obviously very different, and there's different things that affect kind of their underlying health, and there's different obviously social determinants for health. What we find is that the whole food eating approach, at first it feels daunting, but there are cheaper ways to do this, and so there's certainly some ability to address that. I think it needs to, I think for some populations this is going to be this is an approach that can work, but probably takes more support and takes some support kind of with with kind of a view around kind of the food that people are getting, especially if they're getting food from food banks. So I don't think we have all the answers. One of the things that I feel really strongly about and why I started this program was when you practice as a lifestyle medicine doctor, you realize that the first step in the guidelines we pay lip service to. And if we didn't pay lip service to it, we could really, really bend the diabetes curve. And the first week of COVID, when I went online and was doing groups online, it was this realization that, wow, if we have a virtual clinic, we can reach everybody everywhere in the province. And I shouldn't say everybody, because obviously some people don't have bandwidth, but we can reach a lot of people. And we do see that in our program. Our geographies are similar to the province's kind of densities. We reach people of all different economic backgrounds. And so it does level it out and it does make it more accessible. And and I think that kind of if every patient had this when they were diabetic, we would see a change in prevalence of type 2 diabetes. I think we can achieve a large amount of remission because I think this is scalable. And then that starts to allow us to, as we go on, it starts to allow us, and especially if there are practitioners that are interested in different kind of populations, it allows us to figure out, okay, this works great with kind of 80% of the population, but what about that last 20%? Is there more that we can do? So right now we've got a medical director who's looking at creating a South Asian program. So that's kind of one of our first steps, because in BC we have a large South Asian population, and so we're trying to kind of address that. So if anyone's passionate about this and wants to figure out a way to help with particular populations, we're all ears.
Lots of good opportunities for growth and evolution. Well, I wanna end there because we said that we would finish at 12:50. But thank you so much for coming and sharing your passion, your knowledge, and the amazing program that you've built with us. For everybody registered, we will be sending out follow-up information, which will include the website that the program is available. Was there anything you wanted to let any of the physicians know further about the program? If you have a last message for any physicians to reach out or others?
Yeah, so you can just direct patients to lifestylrx.ca. They can self-register. We'll reach out to you to get their referral. That's probably the easiest way. Andrea can connect with anybody and give you a little practitioner. We've got these little prescription pads with a little QR code that you can just kind of really easily hand to people. I think that's the best way. You can obviously kind of fill out a referral form and we'll maybe send some of those out. But just have that lifestyle conversation with every patient that you see, and know that there are kind of resources for those patients.
Thank you so much, and take care, everybody, and have a great weekend. Stay safe.
Thank you.